This video provides a real patient example of how a new partnership between GoodRx and several companies called Pharmacy Benefit Managers, or PBMs, is significantly harming pharmacies. I, Luke Slindy, am a pharmacist, which explains why I have an above average knowledge of how these types of business transactions work. However, in the example provided in this video, I am the patient and have no business relationship with the pharmacy discussed. This is a photo of my actual prescription insurance card. Information about my family has been redacted. Like many Americans, I receive my prescription insurance coverage through my employer. I work for a small company, and as such, our employee benefits are determined by a different, much larger company called CBiz. The Employee Benefits Department of CBiz has selected a company called CVS Caremark to be the Pharmacy Benefit Manager, or PBM, which means CVS Caremark is responsible for my prescription insurance coverage. Like most Americans that receive their prescription insurance coverage through their employer, I have no input into which PBM is chosen for my family and must interact with CVS Caremark if I want my family's prescriptions to be covered under my health insurance plan. This is the pharmacy I choose to use. This pharmacy provides excellent service, and along with other nearby local businesses like the independently owned grocery and hardware stores, are critical to the fabric and identity of my community. I recently have battled facial rosacea, and a physician prescribed oral doxycycline for treatment. A partnership between federal and state governments within the Medicaid program provides comprehensive data available to the public to determine what a reasonably fair payment to a pharmacy is for most prescriptions. Accessing that data, a reasonably fair payment to my pharmacy for my prescription would be $7.47 for the drug tablets, plus $11.55 to pay the pharmacy for all the service and accessory supplies they provide in dispensing the prescription, resulting in a total of $19.02. Now for a bit of history. For multiple decades, prescription discount cards have existed. These discount cards have provided an option for patients without prescription insurance to ensure they pay a reasonable price for their medication. Critically, from the pharmacy's perspective, discount cards are processed through the same technology pathways used for regular prescription insurance. That is, they are processed through PBMs. However, unlike regular insurance, when a discount card is used, a portion of the final dollar amount the patient pays at the pharmacy checkout is actually passed backwards to the PBM and the company marketing the discount card to pay both for their involvement. Pharmacies have always had the option to accept or not accept specific discount cards operated by PBMs based upon the payment and other contract terms involved. Also, most pharmacies decide whether or not to accept specific discount cards under the assumption that it would affect a very small number of total prescriptions filled. Starting in the early 2010s, discount card aggregators first appeared, most prominently a company called GoodRx. This new technology analyzed most of the various discount card programs that contracted with pharmacies established by PBMs and determined the one with the lowest price to the patient. GoodRx then provided the identification information, called a BIN number, for that PBM with the lowest contract price, and the pharmacy would process the prescription through that PBM. From the beginning, GoodRx has made it clear that it is not insurance. Until recently, a patient that has insurance, that is considering whether to use GoodRx, must make the explicit decision between the two. Again, to restate, GoodRx is a data aggregator that collects pharmacy network contracting pricing data from several different PBMs that operate discount cards, and patients have historically had to choose whether to use GoodRx or their insurance, but not both. In 2023, GoodRx announced new partnership programs with several PBMs, including 4 of the 5 largest PBMs in the market, specifically Express Scripts, CVS Caremark, MedImpact, and Navitus, covering 70 or more % of all patients in the country. The announcement shown here specifically refers to the partnership between GoodRx and CVS Caremark, a PBM with approximately 25 to 30% market share of the total prescription insurance market, including, as we've seen, my family. Quote, through the new program, CVS Caremark's eligible members will have automatic access to GoodRx's prescription pricing to allow them to pay lower prices, when available, on generic medications in a seamless experience at the pharmacy counter. The amount paid will automatically be applied to plan members' deductible and out-of-pocket thresholds. Unquote. This announcement appears to dissolve the previous boundary between using insurance and using discount cards. as prices now could be determined by GoodRx, i.e. other PBMs' prices, but the dollar amount would be applied to a member's deductible in their insurance plan. This program was announced to begin on January 1st, 2024. These new partnerships between discount card operators and traditional PBMs caught the attention of industry experts and raised a series of important questions. In a post on the popular Drug Channels blog written by Adam Fine, this diagram was included to help readers understand the business relationships and how the new partnerships would operate. In this diagram, the Pharmacy Benefit Manager number 2 would be the company whose name is on the insurance card in your wallet or purse. In my case, CVS Caremark. The new partnerships allow that company to automatically scan GoodRx pricing data and identify whether another PBM's network price, of the several aggregated by GoodRx, would be lower than PBM number 2's price. If PBM number 2 determines a price found by GoodRx is lower, PBM number 2 then redirects the prescription to be processed using the other PBM's, PBM number 1 in this diagram, bin number, which is provided by GoodRx, and then applies the new dollar amount to the member's deductible. In the process, the PBM number 1 collects a discount card fee from the pharmacy, which is then split 3 ways between the two PBMs and GoodRx. Importantly, what occurs in this process is that the prescription, which started out as a regular insurance transaction, is automatically switched, without the patient's knowledge or consent, into a discount card transaction, with an associated fee collected from the pharmacy. If your head is spinning, that's okay. Next, I will show specifically how this process played out for one of my prescriptions and provide all the data needed to follow the money. Remember my prescription for doxycycline? Without my awareness or consent, CVS Caremark scanned GoodRx's pricing data, again, other PBM's network prices, and determined another PBM, called SurpassRx, had a lower negotiated price for my prescription at my pharmacy. I do not know what CVS Caremark's negotiated price for my prescription at my pharmacy was, but we can infer that it would have had to have been higher than $14.32. Otherwise, this secondary GoodRx redirect process would not have been triggered. So let's follow this through step by step. Step 1. My pharmacy receives both my prescription from the physician, as well as my prescription insurance information, which is bin number 004336 for CVS Caremark. Step 2. My pharmacy fills my prescription and submits an insurance claim to CVS Caremark. Step 3. CVS Caremark determines their network price for my prescription at my pharmacy is greater than $14.32. Step 4. CVS Caremark uses GoodRx to scan other PBM's network pricing data for my prescription at my pharmacy and finds that another PBM, called SurpassRx, bin number 018951, has a network price of $14.32 via a discount card program they, SurpassRx, operate. Step 5. CVS Caremark redirects the insurance claim to be processed by SurpassRx's discount card and records the $14.32 amount to be applied to my deductible for my health plan from CBiz. This was done without my awareness or consent. Step 6. SurpassRx processes my prescription through its discount card, charging a $7 discount card fee to my pharmacy. Prior to this incident, I had never heard of SurpassRx. Apparently, they are a small startup PBM headquartered in the Dallas metro area, founded by people that used to be employees of an older PBM called Catamaran, which was acquired by OptumRx in 2015. Interestingly, this discount card, which my prescription was processed through, says, quote, "This card is not insurance." Step 7. The $7 discount card fee taken from my pharmacy is then split 3 ways between SurpassRx, GoodRx, and CVS Caremark. I have dollar amounts with an asterisk next to each, as I don't know how the $7 is split, just that it is. Somehow, CVS Caremark spent nothing and actually made money on this transaction. Step 8. When you subtract the $7 discount card fee from the $14.32 I paid, my pharmacy is only left with $7.32. This is substantially less than the $19.02 the government has determined to be reasonably fair, and it is likely that the pharmacy actually lost money by dispensing my prescription, even without taking into consideration the staff's time, labels, pill bottle, bag, etc. the pharmacy provided. This is what I mean when I say that GoodRx helped steal $7 from my pharmacy. My pharmacy is being forced against their will by PBMs to accept discount card transactions and associated fees for prescriptions originally submitted as an insurance claim. Prior to January 1st, 2024, pharmacies were allowed to accept or decline discount card programs and the associated fees they charge. However, now that GoodRx has embedded discount card processing and fees inside of regular insurance PBM-initiated transactions, pharmacies have no ability to opt out. Recently, there have been many stories in the media noting the dramatic increase in the number of pharmacies closing and inquiring into the underlying causes of the closures. As someone who is directly involved every day in the fight against pharmacy closures, here are the main causes. Pharmacies are closing because the PBMs that control how pharmacies are paid use nonsense algorithms to determine payment amounts, have no accountability to ensure pharmacies don't lose money by dispensing a prescription, often take money from pharmacies that originated from the patient, like my personal example, and share price-fixing data with their supposed PBM competitors to pay pharmacies less. All of these factors are combining to make it very, very difficult for a regular pharmacy to be a financially sustainable business, and so you are seeing many pharmacies closing and exiting the market. Price-fixing? What does that mean? Theoretically, PBMs should be determining how much they pay pharmacies for each prescription independently. However, if PBMs share pricing data with each other, or benefit from another competitor PBM's prices, as shown in my example facilitated by GoodRx, PBMs can tacitly collude to all pay pharmacies less than they otherwise would. For my prescription, CVS Caremark used GoodRx to benefit from Surpass Rx's pricing. But keep in mind this is just one of the dozens of possible PBM plus PBM2 combinations, all facilitated by GoodRx. In addition to the attention given to algorithmic price fixing by the Federal Trade Commission, recently several U.S. senators have introduced legislation to address the issue. Especially given my home and pharmacy are located in Minnesota, I hope that this form of algorithmic price fixing in prescription drugs demonstrated in this video receives attention from the Senate. If you would like to further discuss the content found in this video, I can easily be found and contacted on LinkedIn. Thank you for watching.